So minimal residual disease in ALL is probably the most useful single prognostic tool that we currently have. However, there are many key aspects to using minimal residual disease effectively in order to be able to treat patients. Firstly, you have to be able to time your minimal residual disease detection at precise time points, and this is very much dependent on your treatment protocol. So within pediatric ALL, the most commonly used endpoint is at the end of induction therapy, which is 4 or 5 weeks after treatment starts, depending on which protocol. And that measurement is widely regarded as the key prognostic tool within pediatric ALL. In adult ALL, we tend to use a time point that's somewhat later. The time point that you choose should be mapped onto a key point in your clinical trial, and also needs to be consistent from one trial to another, so that you are able to build up a body of evidence to show what time point is best for that treatment protocol. But a couple of studies that we have done more recently have shown that although MRD is a really useful prognostic tool, actually you can quite easily enhance its ability to predict relapse if you combine it with genetics. So what we showed in a paper that we published in the Journal of Clinical Oncology at the beginning of 2018 is that if you have if you have genotype-specific MRD thresholds, you can move away from, you can identify patients that have a much better outcome with low levels of MRD, and also a worse outcome with higher levels of MRD by adjusting the threshold depending on the background genetics of the leukemia. So although MRD is a fantastic tool to identify patients that are at least and greatest risk of relapse, it's not the whole story by itself. You need to take into account the other variables that are going on, in particular the genetic background.